So most of us on the line today have made some effort to try and address these shortcomings in our systems. And for me, this is where things become a challenge. I've been trained to be a surgeon. I can understand the human body and those complex systems and interactions. But when it comes to understanding how an intervention is going to have an effect in a larger field in the healthcare environment, it's quite a bit harder. So there's so many competing initiatives and strategies and priorities, so it's hard to know what to do and what effect our actions might ultimately have. And it's no wonder that sometimes all we can do is really just complain about our system. So I hope today, and I know today, Jeffrey's going to share some of his work and show how improvements in quality of care are actually a natural consequence of some of the specific types of environments and work cultures. He'll show us how to create and foster these environments and cultures within our own local context. So without further ado, I'd like to pass it on to Jeffrey now.
Thank you, Tom, and thank you, Jenny. It's a real privilege. I'm deeply happy to be working with BC again, even though I'm not there. I'm in Sydney, Australia, and it's kind of tomorrow morning in Sydney, Australia. It's a real pleasure. So I'm not a surgeon, and maybe that's why you wanted to hang out with me, because I guess lots of you are, and you know a lot about surgery. But what I've been doing, I trained as a psychologist, but I've devoted my career to really trying to understand health systems and how they can be improved. So I'm going to concentrate on the building resilient systems and the improvement in the title. And I know that you have the backdrop and the training and expertise in surgery. So together, I figure we'll be a good team if I concentrate on the stuff that I've been doing and trying to reflect on. So I'm just going to change some slides as we go and make sure I get that right.
So it's just up in the corner here where you see my cursor pointing, Jeffrey.
Thank you. So all that, this one, the arrow?
Yeah, so you'll see my BCPSQC1 arrow here, and just above it, you'll see the little advancing arrow.
Right. Thank you. So that training was a failure. Jenny, you tried hard. Now I'm okay now. So I'm from the Australian Institute of Health Innovation. We've got about 180 researchers, clinicians, doctors, nurses, allied health professionals, as well as computer scientists, psychologists, sociologists, anthropologists. So we're kind of where medicine and the health professions meets the other professions to try and understand how healthcare works and how it can be improved. So we don't have a lab, we don't cut up genes or try and figure out how proteomics works. We're dedicated to try and understand how health systems perform, how they work, and how they can be made to work better. And we've got a lot of resources on our website, so you can go there and follow this up. And also a copy of the slides will be made available for you. So we've got 3 research centres and 3 of us who are directors of the Institute. So we've got 3 research, we've actually got 6 research centres, but we've got 3 substantial university research centres. My own, and I'm interested in change, patient safety, quality of care. Enrico Kawira, who's a doctor who became a health informatician and has done a lot of work on AI in medicine, big data. And Joanna Westbrook, who's interested in safe systems of care, does work on medication safety and aged care and systems improvement. So as Jenny said, I too would like to add my acknowledgement to the traditional custodians of the land. And we too in Australia have a large Aboriginal population, and so I extend that respect to our Aboriginal and Torres Strait Islander peoples. So I wonder, can we try a voting system, Jenny? Who has been amongst the attendees to Australia?
Sorry, can you just repeat that, Jeff?
Who has been amongst the audience to Australia?
Well, if everyone can just use your check mark or your X button and maybe let us know if you've been, oh, Brett's been to Australia, okay. 2, 3, Jim's been, 4, Christina. So we're looking at least half a dozen people that have been. It's a long flight, very expensive, so.
So
Carolyn.
Yeah. It is a long
and
flight.
Tom's been too. Look at that.
It is a long flight, but it's worth it. Okay, so so you'll know that Australia has a very similar health system in many respects, although it differs also from Canada. We share the same Queen, and we have a Westminster system of politics and government, and we have states and territories, and you have provinces, and so your health systems are more decentralized to the province level, and ours are more centralized. But still, there's very much commonalities between our system works and how yours works. So it's kind of neat to work from Australia to Canada and vice versa, I guess, because of we share a lot of values and economies too. There's a great similarities between resource-rich economies in Australia and Canada. Okay, so improving surgical care. So let me start off with a few comments on Australia. One of the things I am is President-elect, the incoming president for the International Society for Quality in Healthcare. And Cliff Hughes is a cardiothoracic surgeon some of you will know or have met or know about. He was also a past president of SQAN, the International Society for Quality, and he's a cardiothoracic surgeon. So in preparation, I sort of talked to him a little bit about surgery in Australia to do a little bit of scene setting. So we thought through how do we improve surgical care, and one of the starting points for us in Australia was to understand really what the problem is. And lots of information comes from audit and incident management and studies. And one of the things we've been thinking about, Cliff Hughes and I, for a long time, more than 10 years, is, you know, often we demonize the system, we criticize the system, and Tom, you said that. But in fact, we can learn an awful lot from things going right as well as wrong. I think some parts of medicine do that better than others, and I think surgery does that well. With new techniques and new ways of doing surgery being developed around the world and then being adopted in other parts of the world. So surgery, although it doesn't, international surgical care, although it doesn't look like an international sport, it looks like an individual patient and clinical team in the theatres sort of sport. It actually does do that probably as well, if not better than many disciplines in medicine. We're particularly taken with the idea that we can learn from things going right, and I'm going to come back to that shortly. So Australia has a number of statutory expert committees for investigating deaths under anaesthesia and audits of surgical mortality, which are managed by surgeons for surgeons. And just a couple of quick bits of data, which will obviously be similar in Canada. Deaths from anaesthetics has fallen really in our lifetime dramatically, and now it's much more safe to have an anaesthetic procedure. Also in terms of, in Australia, audited deaths with a consultant surgeon in the theatre has also been improving in Australia. So the number of audits that are done on operative deaths or operative related deaths has really been rising over a period of years, and it's at pretty high rates in Australia. So, but what about improving care in the province? So I took from your website really, and from discussions with a couple of people, what you were trying to do in your project, the SQAN project, Surgical Quality Action Network project, which many of you, of course, are part of. And this is what you said on your website. The vision is to decrease complications and infections, provide more evidence-based care and better outcomes. And this is with large numbers across the province. In addition, there's a number of providers who've joined the network, and there's a saving has been realised of 12,000 bed days over a 5-year period. And this is sort of a province-wide aligning the activities to other initiatives that are going on. And I think that sort of systems approach, while surgery is intensely personal and individual with the surgeon and the surgical team and the patient, this is also a concerted effort to try and improve the system and raise the bar across the province. And I think that's really best practice. That's really good because it means people can learn from other initiatives and each other. And this is a snapshot of the Advancing the Surgical Quality Agenda, reporting back, how did you do? And there's some really nice data here, snapshotting the progress that you're trying to make with SQAN, with your surgical quality initiative. So that's all right, but you didn't get somebody to sit in Sydney, 11 hours ahead in a time zone for me to talk about what you can read on a website. So I thought I would draw down on lessons around the world on improvements. And I'm going to take some examples, not necessarily in surgical examples, but just to give a snapshot of this. And so I've been editing a series of books on international health reform, looking at up to 152 countries, as you'll see, and what they are trying to do to try and reform and improve their health system. So I thought we might draw down on that experience. So I've edited with colleagues 3 books so far. One, Health Reform, Quality and Safety in 30 countries, and that did not have a Canadian chapter, I'm chastened to say, I'm sad to say. Then the second book, Success Stories from 60 countries, where we asked 60 countries each to tell one success story in their health system, not necessarily surgical, and Canada had an entry in that book. And then looking at, well, what's the future of health systems? What can we say about activities going on around the world now, today, projected across the next 12 years to 2030? What do we think is going to happen to create sustainable projects like the one like SQAN and other projects that you've got improving surgical care? And what do we think is going to happen across those 12 years? Because one thing we know about healthcare, it's not getting less complex, it's not getting less challenging, and we're dealing with more and more complex chronic patients with aging populations and challenging conditions. So life is not likely to get any easier wherever in the health system you are. So what's going to happen in the future? What do we predict for the future? Now, I'm going to concentrate on this book, the middle book, which was published in 2018, last year. But I've got summary papers on each of these, and if anyone wants that, if they're interested in beyond Canada, what's happening in the rest of the world, I can share those with you. So in terms of the first book, there was 26 chapters from the 30 countries and 14 mentions of surgical procedures. So 14 of the chapters dealt in some way or another with surgical procedures. There was 58 chapters in the second book, and 17 of the chapters look at surgical procedures. And there was 57 chapters in the third book, covering 152 countries, in fact, with 12 projects on surgical improvement mentioned. So although I'm not a surgeon, I'm doing work in improvement in health systems generally and in surgery particularly. So let's drill into this middle book. The data are there on the slide. There's 106 contributing authors from 60 countries, 5 low income, 22 middle income, and 35 high income countries, covering 2/3 of the world's population, providing care to them. So we asked each chapter writer to choose an example, or each chapter writing team to choose an example of success in their health system, analyze the case, identify the lessons learned, advance recommendations, and then write a chapter, which I edited and amalgamated the chapters into a book. So here's a snapshot, and I'm not going to go through each of these because it's just a very quick tour around the world. These are the kinds of things that people chose to write about. And the US chapter, for example, was improving safety in surgical care. So that could be useful, and I'm happy to make that available. Canada was improving stroke outcomes, and so on and so forth. So right across the world, here's Europe. There's a lot of chapters on Europe, some of which are to do with all sorts of issues, but some have to do with surgery. But even if they're not, there's lessons to be learned about improvement, which I'll summarize shortly. Africa. It's harder to get chapter writers for Africa. They don't do this sort of research, this health systems quality and safety kind of research, as much as the more wealthy countries. Eastern Mediterranean, a number of countries. The Eastern Mediterranean has challenges because it has some of the richest countries in the world and some of the poorest side by side. So they have challenges. Whoops, I think I skipped over a slide accidentally, maybe. And Southeast Asia and the Western Pacific, where I am, with chapters from China and Australia, New Zealand, Fiji, Hong Kong, Taiwan, Japan. So, and Eastern Mediterranean. Sorry, I'm going backwards. I'll just go Southeastern Pacific. So what are the key messages? So, you know, what we often do in healthcare is we critique the system. And Tom alluded to that. And we work in a system that's sometimes not as functionally supportive as we would like, even those of us in wealthy systems like yours and mine. And so we end up criticizing the system, and lots of academic work does that too. And people do interventions to try and improve things. So this is a more positive deviance approach. It says, what goes right in your health system? And one of the interesting things when we asked these 60 countries, and in the next book, 152 countries, to write a chapter, everyone could provide multiple success stories, regardless of if you're in the lowest income countries, regardless of your political structure or the resources you had available. So that was very encouraging for us to think that every country has multiple success stories that they can share for the benefit of other projects going on in that country. And we often don't do that well, share successes, say, across Canada with projects going on in Canada. But we do a very poor job sometimes of sharing success stories of improvement projects across the world. And I'm very interested in that as a phenomenon. What can we learn from each other? I suppose we go to conferences, and that's one way. So this is learning across boundaries and borders, learning across geographical borders, learning across professional roles, and learning across disciplines. So, just going to check I didn't slip over a slide. Yes. So, one of the things we've learned from this and other work that we've been doing is that there are a group of people who think that our improvement strategies would be relatively easy, or should be relatively easy, or are relatively easy, and all we have to do is issue more policy, or issue a new guideline, or mandate something, and it will happen. And that's obviously not so. And I don't want to criticize people sitting in ministries of health and health departments, because they're part of the bigger team trying to improve healthcare. But it's true that there are people like that, and some people who are relatively linear thinkers, who think that improvement has to be basically on a command and control model, But that's not the case. All improvement takes place in the most complex system anybody's ever devised, the health system. So we've been doing a lot of work on what's the nature of this complex adaptive system that we are trying to make improvement on and in. So complexity is quite easy, even though it's complex, to summarize, and I've done so in a slide. It has relatively autonomous agents, especially on the front lines of care, and that's especially so in surgery, interacting. They're self-organized. They don't wait for the policymaker or the manager to tell them to organize. They organize. It's a collective. They're networked together across patient care, for example, referral networks. They have rules, but not necessarily the rules in the policy manual. They have rules that emerge that are sensible for the people in the team. And I'm thinking about the frontline care, and I'm thinking about the operating theatre. There's emergence, which is just an academic way of saying things happen that you can't predict relatively well. There's always uncertainty, and surgeons, if there's any group knows that, it's surgeons. It's adaptive across time. All systems change, but not necessarily to the rhythm and the beat of the policy manual and the policymakers' pronouncements. It's dynamic. all systems also, complex systems are bottom up. They're not just governed by top down. They're always in transition to something else. They are governed as much by feedback as any other mechanism, and all complex systems are path dependent, which is an academic way, a complexity science way of saying it matters where you came from. The pathway to where you are now, to some extent, determines where you are now. And we know that through studies of culture, where the culture is like it is in your operating theatre suite, in your hospital, in your department, a lot because of what happened in the past, which gets imported into the now. So that's a summary of complexity, and I'm going to work with that a little bit now. So it follows that if your mental model is this, then you will assume certain things, that policy and budget cascade down, and the people on the front lines of care are going to follow your instructions or your mandates or your suggestions or your recommendations. So clinical guidelines and policies and procedures and standard operating rules are all based on this model. But actually healthcare doesn't look like that. Healthcare looks like that. And so any practicing clinician knows this. This actually isn't a model, by the way, of the whole health system. I don't have a slide big enough. This is a model of the interactions in an emergency department, just one emergency department. So it follows that we may have, many of us, the wrong model for improvement. We have some linear model in our heads which says, if we do this, mandate this program, issue this policy, then we're going to get improvement on the front lines. But if healthcare is really like this, then we need different models for improvement than a top-down command and control, policy-led, minister-led. Minister-led. So the next minister who comes in often says, I'm going to restructure the system, and then we're going to get people doing, hand hygiene or whatever it might be, following guidelines, improving evidence, doing less harm in 2 or 3 years. But if you've got a model like this, then it's not going to be that simple. So, there's a number of frameworks for this. We like this framework, which says there are some things in healthcare that are simple, some things that are complicated. Firing a rocket and getting it to Mars is complicated, but it is actually predictable. You know when you will, assuming something doesn't go wrong mechanically, you know when you will reach Mars, and you can compute the trajectory. Or complex, which is most things in healthcare, or chaotic when things are out of control. So with that model, we can see in healthcare, we've tried to say something simple like a checklist, although, as it turns out, checklists aren't as simple as we thought they were, as at Al Gore one day thought they might be, because they're embedded in a culture and practices of people. Complicated, say the care of one patient, taking vital signs or something like that, taking blood pressure, giving them a series of tests and then the result. Something that's complex, obviously an operating theatre interaction on any case, even a routine case, is complex, and chaotic, where things are out of control. And obviously we don't want that in healthcare when things are out of control. So just a quick pause from me, just to check back. I wonder if people want to use the chat and give some feedback on experiences of complexity. I'll pause for a few moments. It is exhausting, someone says. I hope you don't mean my talk.
I totally mean your talk, Jeffrey. I also see people are saying it kind of builds over time. So that just seems to happen too. You're a perfect example of the checklist, right? You're like, oh, this is an easy thing, and then it starts to cascade, right?
Sure.
I see Claire saying difficulty capturing all the possibilities. That is very true. It's hard to think through everything in advance.
And that's true. The checklist, there's that great New England Journal of Medicine paper. Some people criticized it, but, it showed in a number of sites that you could use a checklist and decrease mortality and improve things. However, It didn't come problem-free because it wasn't as easy to implement in some settings, and people find it difficult to sustain it across time.
Mm-hmm.
Other people are saying chaos can be predicted, or chaos is a bit like the weather 10 days out. You can predict some aspects of it, but a lot of it can't be predicted, and things can go chaotic very quickly.
Mm-hmm. Yeah.
Yeah, somebody's written fantastically. We could use some of these quotes in our next paper. Of course, I won't without your permission, but deep systems problems are at the root cause of the challenge, and sometimes it's not obvious on the surface, and that's true. We sometimes try and solve the surface problem, but the deeper manifestation of the problem is below the surface. Yes, the iceberg phenomenon is complex. I'll come back to some of those. So thank you for those inputs. So let me continue on. So we've written a white paper, and this is a freebie. Whilst publishers whack a big price on the books that we publish, which I'm always fighting with them about, because I think the price of books is way too high, especially when we do all the work. But we wrote a white paper, and it's on our website. It's not specific to surgery, but it tries to analyze this idea of healthcare being a complex adaptive system and what we need to do to factor in that complexity to solve real problems rather than superficially using linear models, linear simplistic cause and effects models to assume that we can fix and improve healthcare. So that's there on our website, and we can make that available to you. So everyone struggles with complexity, as you mentioned in some of you in your comments. So here's a project we did a couple of years ago. So we were working with clinicians who treat Lynch syndrome, and we said, what do you do? What do you do? And they said rather simplistically to us, well, we screen, and if the patient's a high risk, we refer them. And we said, okay, tell us a bit more about what you do. And they said, well, we just told you. We screen, and if they're high risk, we refer. And then we sent a couple of anthropologists and sociologists into the workplace to look at what they did. And then we mapped it. So they were telling us how they imagined their work was done, work as imagined. And it was quite simple in their minds, but this is the actual model of how they treated Lynch syndrome. And this is only a partial model, to be honest. We clustered some things together in some of the boxes and some of the call-outs. So even to those working in a system, because they get routinized into the culture, enculturated into it, they stop seeing all the aspects of the system that they're probably wanting to improve. They tune out, and they only tune into the things that are interesting to them on their particular path to get their job done. So even people who are well-versed in their own culture tune out to aspects of the culture. So often you need an external advisor to help you understand your own system. And that's not being disrespectful to the people who work in the system. You can't always see all the things that are going on in your own system. So it's quite useful to get somebody external. Adol Gawande said that in a nice paper he wrote, by the way, I think for the New Yorker, where he wondered why tennis players have coaches and why people needing financial advice had financial advisors, but rarely did surgeons have coaches, and rarely did someone come into an operating theatre and observe the system that the surgeon was operating in, and sort of give some feedback on the performance of the system in the operating theatre. I was really struck by that. So the legitimate question people could ask now is, okay, but what actually works? Well, there's a branch of Cochrane, the evidence-based accumulation worldwide network, called EPOC, which is about what works in terms of systems change. And so these things have been shown to work in randomized trials. Audit and feedback, sometimes in some places, depending on the circumstances. Local opinion leaders, and if surgeons don't know that, no one does. There is often a surgeon who has no place in the hierarchy, who's not, not in charge of anything managerially, but is an opinion leader who is disproportionately influential in how things happen in that hospital. On screen point of care reminders, that's a very specific thing that there's an RCT on. Interventions to promote safe and effective use of medicines by consumers, but no single strategy. Educational outreach, and every drug company knows this because they do educational outreach of their particular suite of drugs to clinicians directly, and tailored interventions strategies to change health practitioner performance. All of these work sometimes in some circumstances. They all have an RCT, and all of them have something going for them, but nothing works consistently forever, universally, because there's no free lunch in improvement. There's just hard work and smart application, which I'm coming to. So that brings us to cultures and teamwork. So we've done a lot of work on this because complex systems are really the manifestations of local cultures and teamwork. We've done a lot of work on that, and I'll just dip into some of our work on this. So what's culture? It's a kind of set of beliefs, ideas, practices, and behaviors, and I guess what we're trying to do is influence it, shape it, nudge it, change it. So it's the way we think around here and the way we do things around here. One way of thinking about it, another way of thinking about it is it's our collective worldview, assumptions, outlook, norms, and values. And you kind of know that. And every training doctor knows that when they rotate through different parts of the health system, because they go to one part of the health system, even one part of the same hospital, and they see a different set of cultural characteristics. And then they go to another part, and even if it's in the same hospital and there's a kind of general cultural milieu, the subculture in a different department is different, and that's emerged over time. So it's collectively within the culture or within the subculture, the things we agree on and the things we've taken for granted. We start to be enculturated, socialized into the culture, and we take things for granted. So here's a model, there's many models for this. The iceberg is above the waterline. There's the observable behaviors, practices, and discourse, the way we do things around here. The stuff, if you go into the theatre or somebody else's theatre to watch things happening, it's what they're doing, their practices. And then below the waterline, it's the collective beliefs, attitudes, values, and philosophies. And tapping into that helps you understand why we do the things we do around here. So there's books on this. I co-edited a series of books in a series of chapters in 2010 on, and there's aspects of the characteristics of surgeons and allied health professionals. And one of the things we discovered with 10 years of work on cultures is, despite this notion of multidisciplinary teams, healthcare is highly tribal. And people do fold back in on their professional tribes. So anthropologically, things are very rich in healthcare because of the tribal nature of it. Now, we've been talking about multidisciplinary teams for a long time, and I'm going to come on to this and show a couple of studies. Before I do, though, it's logical for some people to be thinking, okay, well, we're talking about culture, but what's the relationship between a good culture and patient outcomes? In other words, if you have a good culture or you've nudged a culture that's not so good, a toxic culture, or one where people don't work well together, and you've nudged it into a better one, was it worth the effort? Will you get better organizational outcomes or patient outcomes, clinical outcomes? So who believes that if you have a better culture, you'll get better patient outcomes? Well, we could do a chat box or a vote on this, but the answer is obvious. Everybody believes that if you've got a better culture, you're going to get better patient outcomes. So it's well worth the time. So we did a systematic review on this, published in 2017, been cited a lot already. And we looked at 62 studies. And what we showed is that that is true across 62 studies, where their studies had associated culture, workplace culture, usually in hospitals, often in departments. If you have measured the culture and you've related that to outcomes, clinical and organizational outcomes, those with a better culture got better outcomes, or those who were able to change their culture from a worse culture to a better culture and measured it got better outcomes. So this is well worth the effort to improve culture, to shape culture so it's better, to get better outcomes. So that's what we now know from that systematic review. So here's an example where we've been playing with these ideas. So this is a translational cancer research network in eastern Sydney, Australia, on the coast, you know, where those nice beaches are. So in 2012, we got a bunch of people together and got a large grant to do so, a $6 million grant. And we put the clinicians who were working on oncology patients, cancer patients, with researchers like me together and said, can we improve the system and get more collaboration and enhance the way we work together, including surgeons operating on cancer patients. So that was the network in 2012. By 2014, we'd worked intensively together and got much greater levels of collaboration. Each dot is a person and each line is a connector between those people. By 2015, we had this, and by 2017, we had this network. So we've really done some work across a 6-year period, and this is ongoing. We're doing this survey now to see what 2019 is like. So we've really engendered the capacity of a network to work together to create more care that's in line with evidence, is informed by research, and is connected up between all the people who deliver cancer and the researchers. So I can share those papers with you for anyone who's interested. So this is really working with the complex system, not saying how does policy get enacted top down, but what's happening on the ground, on the front lines of care as people work together productively and collaboratively. So, however, whilst we're showing networks like that and really nice results on improving collaboration to improve care, it's still the case that clinicians are tribal, and I mean clinicians in that broader sense. So here's a study of an emergency department, 2009, somebody's PhD, in fact, Nerida Creswick's PhD. What we did was we got a whole bunch of people together and in an emergency department and said, who would you go to if you had a problem? And the blue dots are nurses, the red dots are doctors, the yellow dots are allied health staff, and the green dots are admin and support. And so what you see from, and the size of the dot, by the way, is the length of seniority of the person. So big dots have been there longer. And the lines are connections, i.e. people you would go to if you had a problem. And so that's pretty dense network. It's a good network because it means lots of people would go to lots of other people if they had a problem, which is encouraging. But look at the colors. Who would you go to if you got a problem? Someone like you. In network theory, that's called homophily, or birds of a feather flock together colloquially. And what it means is, despite this being quite a good multidisciplinary team, it folds back on its professional disciplines a lot. And that's not surprising because that's how we train people. So here's when we ask them, who would you go to for medication advice? If you had a medication problem, who would you go to for advice? Again, it's tribal. And the admin staff go to the edge of this network map because they don't really have medication problems, but some of them answered it theoretically. Again, though, it's tribal. And then we ask them, who do you socialize with? Who would you go to coffee with, or who do you have lunch with? And again, it's very tribal. And there's some isolates who don't go to coffee with anybody. So what we can see is, while we can induce more collaboration, we don't quite get there with multidisciplinarity, perhaps as much as we'd like. And so that could be a problem in some of your theatres and some of your networks. So what these studies signal, though, is better teamwork, trust, and collaboration is probably going to work for you in terms of getting the right people together to try and make the improvement that you want to make in your surgical quality network. So if you're going to try and change the culture, some suggestions from our work are, if you want people to have a better culture or improve their capacity to recognize internally their own culture and their own cultural characteristics, because often the fish doesn't know it swims in water and you don't recognize your own cultural characteristics after you've been there for a while, or you want to make your current culture work better, then maybe use a change model and there's lots. Maybe take some baseline measures of your culture, anecdotally or through survey or observational, or get somebody external to come in and observe your culture and say, well, what is it like? And feed that back to you. You have to enroll your colleagues, and our network maps show how that's important. And you have to create a critical mass of support of people who want to change the culture. And sometimes the very people who you want to change in the culture are the people holding it back. And so they need to somehow either be brought into the tent or left out of the tent while we get on with the job of changing the culture without them. So that's site-specific, and it depends on the nature of the problem you have. Also, we see people sort of walking around the health system saying, oh, we're going to change the culture, or we're in the middle of a culture change. But they don't really have a vision for what culture it is that they'd like to have. What's their game plan? What will the new culture look like? Who's going to help you shape it or reshape it if you've decided that this is worth your efforts? Who's going to hinder your efforts? There's always what we like to call naysayers, people who are against any change because it doesn't suit them. By when will you hope to achieve this improvement? What steps will you take along the way? So lots of times we see people running around saying we're changing the culture, or we want to improve it, or we've got a hopeless culture, we've got to do something about it. But they don't have these things, really a game plan for what they're trying to do, and they don't share it with people. Next thing, when we were talking about in prep for this, is to talk a little bit about leadership. My view is every surgeon is a leader because they run things. They run a bunch of patients. They run the operating theatre is their domain for the time that they're operating. So this is very important. And I've been talking a lot with the Royal Australian College of Surgeons about this. I'm one of their advisors, and I speak a lot at their conferences. So I published a paper on this a while ago, and I'm going to lead to finishing on this. I'm just going to finish with a couple of themes, one on leadership and one on, well, what does a resilient health system look like? So in terms of leadership, so let me ask you this question. What does this equation mean? It's a rhetorical question. I won't take a vote on it. So I published a paper a few years ago with this as the title. And so I thought, this would be interesting. People would see this as the title of the paper, and they would be intrigued to visit it, and I'd get cited a lot. Because, while your currency as a surgeon might be beds, my currency is citations and papers as a researcher. So what it says is, leadership in healthcare is not the same as the sum of all the management activities that you see in healthcare. And what I'm trying to do, I'm trying to be probably too smart for my own good by titling a paper in the literature with this equation in it. I'm trying to say that leadership is different from all the management that you see going on in health systems. There's lots of management, budget management and micromanagement and trying to get people to adhere to guidelines or policies and so on and so forth. But that's not leadership. And we tend to think, or some people in health systems think, if you just do more management, you can manage your way out of the situation. But I think there's less leadership than we need in healthcare, in many parts of healthcare, and more management than we need, especially micromanagement. So that's what it means. And what I'm saying is, there's often, as I observe the health system, as I do research across health systems, there's too much short-term management and not enough long-term leadership. So leadership is just more than the sum of its management parts. And so here's what I've drawn down on a toolkit for leadership, and you can test yourself about this, of the qualities of a good leader. And I think this really applies in surgery. And this is changing the model on the right-hand side from the boss to the leader. Of course, you need a bit of both. You need to be the boss and the leader, but I guess you've got to get that balance right on the two different models. So I think a good surgical leader displays empathy, not just for the patient, but for staff that they work with, that work for them. Consistency, honesty, that they've set a direction for the future, that there's effective communication, which includes people who are more junior to the surgeon or allowed space to talk, that there's flexibility and a level of conviction. And so those are mine. You'll have some others, but I think they're pretty good qualities for a good leader in surgery who's going to lead a project to try and improve surgical care. So I think it's quite useful to reflect on how you influence the culture as a leader if you're a surgeon leading in the operating theatre, or if you're a surgeon with a bigger job leading a whole network across the province trying to improve care for up to 200,000 surgical interventions each year. And finally, and I'll finish with this, and I think, Jenny, by a stroke of luck, I may even be on time. Let me put
well done.
Finally, if you're still with me, and I hope you are, and I hope this has been useful, resilient healthcare. We've been doing a lot of work on the natural properties of the health system and its propensity for resilience, the individuals who deliver care, who get bashed around a lot just by doing the job they do, but also the health system. So we've published 5 books on that. I co-edit this with a bunch of people around the world, including some colleagues in Canada, which we call our Resilient Healthcare series. And it's this argument about safety too, which we've been champions of. So, you know, clinicians get bashed around the head a lot, even though we say it's a no-blaming system, by the fact that if things go wrong, you could be held to account or blamed, and surgeons know this better than almost anybody else. So everybody gets bashed over the head by somebody sooner or later, with 10% of cases have some sort of adverse event and produce harm, and some of that's preventable. But in fact, the amazing thing about healthcare isn't that, in my judgment. The amazing thing about healthcare isn't that it produces adverse events in 10% of cases, and of course we need to do things to try and ameliorate that and improve that. But the amazing thing about healthcare is in a system as complex as the one I've been describing, it produces safe care and no harm in 90% of cases. We labeled that safety too a few books ago. This is from Eric Holnagel and Bob Weers in the US, Eric Holnagel in Denmark, and myself. We've co-edited this series of books. And so we think people have been looking at when things go wrong and designing inquiries and incident monitoring and root cause analysis and hand hygiene and handovers and checklists and a lot of other things. And we've been focused on trying to reduce harm to zero harm if we could. But what we've not looked at is the full health system, including when things go right. And so we've been trying to redress that balance and understand how come health works when it works, and what is the nature of the system when it works well. So safety 1 is where the number of adverse outcomes is as low as possible, and we've been doing a lot of trying to make sure things don't go wrong. And safety 1 is where the number of acceptable outcomes is as high as possible, trying to make sure things go right. So we think in an improvement network like the SQAN network, there should be and I know there is, elements of both, yes, we don't want to have errors and we want higher quality, but we want to make sure things go right as well, and how can we learn from that? So few people in the past really looked at why things go right so often. Individual clinicians know in their practice, but lots of people kind of haven't looked at this systematically, and we do a lot of studies and write books on this. So can we shift, my recommendation is, can we shift the emphasis to a more positive approach, because there's enormous amounts of good care occur. Can we capture the benefits of that and try and factor in making sure things go right more often? So lots of people, and you know, I ask people, are you on the list, are not on the front lines of care. And they're doing work as imagined, and they're trying to issue more policy and issue more software and issue more regulations and issue more studies to the front lines of care to try and make things go right. But the blunt end of the system, that blunt end tries to shape, influence, and nudge behavior. And what they do seems logical. And in healthcare, people have designed, mandated, or encouraged lots of tools and techniques to reduce harm. Root cause analysis, hand hygiene campaigns, you know them all. Meanwhile, work's getting done often despite the policies and rules. And people do workarounds. Here's my slide for this, which is humorous. Instead of actually following the policy deliberatively. And so I've got a couple of studies on this where doctors and emergency departments, their life is full of interruptions rather than what it looks like in the policy manual. And you can read up on that study. and your work is like that. So the bottom line is we think encouraging culture change, doing leadership better, looking at what goes right, not just what goes wrong. When something goes wrong, we could start not by bashing the person over the head who has contributed to that, but understand how come it usually goes right. Being more proactive, in other words, about safety, and being thorough as well as efficient. So that completes my feedback on some of our work and some of the things that I've tried to make relevant for your interests as a SQAN, as a surgical quality network. And here's a big wave for us in Sydney. I'm tragically sad to report to you it's wintertime here, and it's only going to get up to about 20 degrees and sunny today. So I'm sorry to tell you about our bitter cold winter.
That's warmer than some places in British Columbia, Jeffrey. You're just totally rubbing it in right now.
I thought I'd finish on a high note. So, sorry I ran a couple of minutes over, but I'm happy to take questions or facilitate a discussion. Thank you very much.
I see one question already coming in, and Kate's asking about the research around recognition. So has there been any methods that have been identified as effective, perhaps at the local level on a team basis, but maybe also from the Quality Action Network perspective, how to recognize larger successes too?
Yes, sure. Look, one of the problems is there's 29 million papers in PubMed. There's 11 systematic reviews and 75 randomized trials published every day. So people like me are causing some of the confusion and complexity. So there's a lot of small-scale studies on localized improvements. One of the problems is many people do projects like the Surgical Quality Action Network and don't write it up, don't help the rest of us in other provinces or other parts of other health systems to learn from that. And one of the problems is we don't treat this as, we treat it as an action thing. We don't have, for example, a team running alongside it, providing feedback to us and evaluating it. I'm not criticizing you. Everyone does this. Many, many projects like SQAN have occurred, and we haven't written them up adequately. I'm also self-interested in this, of course, so I'm declaring my conflict here. I like doing research on these sort of things, and that's what I do for a living. But I think we could do a better job of really doing a project like this across years, a bit like our Translational Cancer Research Network, where we're mapping it across time with the network becoming more dense and more collaborative. So I think we could do better at that, run research projects alongside real-world action projects and do more work to write up studies of localized improvement where people have found things work.
I see another question coming in, and it's a really good point, Kimberly. The focus of the things that go right with safety too reminds her of positive psychology. So are the two fields related at all, have you seen, Jeffrey?
We didn't come out of that discipline. The Resilient Healthcare Net, the Safety 1, Safety 2 stuff came out of resilience engineering. You know, when you're on a plane, you notice the wings. If you're over the wing, the wings actually flex and adjust. They're not static and fixed. A plane has been designed to be resilient. And so we transported that idea of the resilience of the health system flexing and adjusting over time into healthcare. But it is a more positive view that the system flexes and adjusts and produces good results quite frequently, much more frequently than many people give it credit, because they are focused on when things go wrong. So we didn't come out of the positive psychology tradition, but there are many connections. And I love Marty Seligman, who's the happiness psychology person who's been doing this longer than anyone else, and his work. And you can draw down on that a lot. So there are some clear connections.
Another question coming in, Ray's commenting on the power of observation as piecing apart work as done versus work as imagined. And as someone who's been the one with the clipboard following someone around doing a process map, I can certainly attest to that myself. So do you have any comments on that, Jeffrey?
Sure. So, I mean, we've played with this quite a lot in our books, and there's many chapters looking at this. So the notion is on the front lines of care, the work's getting done. The real work of the health system is getting done. And people are flexing and adjusting and accommodating and keeping patients safe and, you know, treating people and providing good care, and sometimes harm, but mostly good care. And that's the nature of the health system. It's a complex, adaptive, resilient system, if I can string some jargon together in the same sentence. However, the people who are doing work as imagined are offline from the front lines of care. They're in a management or policy job, or the media, or even researchers who don't do research with the front lines of care. And they're making observations, they're issuing instructions, they're issuing policy, they're doing work as imagined. And so often the policy manual or the guideline doesn't quite fit this particular patient, or even the study, the randomized trial, doesn't quite fit this particular patient or this particular patient group. So I think recognizing those different perspectives on the system and trying to reconcile the two. So for example, we've been imploring policymakers to make their policy less dense, less like a big telephone book,
right?
And to recognize the real behaviors and activities on the front lines of care. So that the third book we wrote in this series was called Reconciling Work as Imagined and Work as Done.
Well, it is at the hour, so want to respect everyone's time, and I see Kate giving a thumbs up to less dense policies, and I know Kate's actually an evaluator, so she's probably really happy with most of the stuff you're saying today. And Jeffrey, thank you so much for joining us, for sharing your immense amount of wisdom about this. And I know that this is likely going to be a resource that we'll return to a lot in BC. So anyone who's interested, we'll post the resources that Jeffrey mentioned, as well as the slide deck and the webinar recording on the BC PSQC website. And you can navigate to the SQAN webpage from there. And honestly, Jeffrey, thank you so much. It's been such a treat working with you, getting towards this, and then being able to just sit back and watch you work your magic. So thank you, and thanks everyone. Go enjoy your hot August afternoon, your summer afternoon here, and thank you for dialing in and working with the time zone change for us.
Thank you very much indeed.
Great. Thanks, everyone.